Welcome to In the Trenches. Good afternoon. This is going to be a very brief In the Trenches. I asked my medical student what she wanted to learn about. And she said polymyalgia, rheumatica, gout, and multiple myeloma. So what I'm going to do, I'm going to say a few clinical pearls on each of these. Polymyalgia rheumatica we see in the office, usually in people, it's very rare under age 50. Patient presents with pain, and there is pain, but there is no weakness. Okay, it's usually in the neck, the shoulders, and the hips. You may have systemic symptoms. If you suspect that, you want to make sure you do not have its cousin, giant cell arteritis, and if the patient is experiencing headache, jaw claudication, or visual changes, that puts them in a different box. And about 15% of PMR patients will get giant cell arteritis. Assume you ruled that out and the patient has these symptoms. The diagnostic test, you get inflammatory markers, and usually they're elevated, SID rate and CRP. And then you treat. And the classic treatment is steroids, and the pro is you give them steroids, they get better. Usually you start with 15 to 20 milligrams, and then you taper it after a week or two, and it might take a year or maybe longer to get off the steroids. You don't give super high doses, but they will get better. They will get better in 48 to 72 hours, and if they don't, you have to think of alternative diagnoses. That's polymyalgia rheumatica. That's something we see. Okay, muscle pain, joint pain, muscle pain. Okay, no weakness, and no tenderness. Okay, if there's weakness with the muscle pain, think of polymyositis. If there's tenderness with it, you could consider the spectrum of diseases associated with fibromyalgia. Gout. Gout is something else we see. Acute gout, see in the office, probably see it every week. It's precipitated usually by something that rapidly increase the uric acid or decrease the uric acid. And although patients have gout, they all don't have high uric acid levels, and you may or may not want to get a uric acid level. Most common place for precipitating these crystals is in the great toe, and that's called podagra. How do you treat this right away? The classic thing is colchicine if you've had symptoms for 36 hours or under. But the most practical thing in my mind is to see if you could refer them for rheumatology and they could inject the joint. If they don't have a diagnosis of gout, then you can make the diagnosis. They could aspirate fluid and look at it under a polarized microscope and look for negative birefringence. Okay, you could also use prednisone, and if it's a younger person, they have no comorbidities, you could certainly use non-steroidals. Most of these patients have hypertension or some chronic kidney disease or heart failure, and you're not going to use NSAIDs in them. Once you're stable, then you'll make a decision on whether you want to lower the uric acid with a uric acid lowering agent. The most common one being allopurinol. And you may or may not want to wait a certain period of time, and this has changed in recommendation. They're giving it closer, but normally they have to be on something that to prevent a gout flare as you're acutely lowering the uric acid, so they need to be on colchicine while you start that. But the key is any level of uric acid can precipitate it. And you know what could transiently elevate your uric acid? Alcohol, seafood. What could transiently lower your uric acid in medicine, like losartan and ARB, which is uricosuric. Sometimes you don't find the cause, but it's actually these fluctuations in uric acid. The other big thing is diuretics, especially in the hospital. You have heart failure patients who come in heart failure and you diurese them. All of a sudden they develop a low-grade fever and a swollen toe, and it's the gout. So this is something that you see a lot. Once you're treating the uric acid level, you want it under 6. Third thing you wanted me to talk about is multiple myeloma. This is the second most common hematologic malignancy, secondary to non-Hodgkin's lymphoma. How are you going to diagnose this? You're going to diagnose it 3 ways. Protein studies, okay, and the most important protein study is serum-free light chains. You will get a serum protein electrophoresis. This is for the heavy chains, and you'll get quantitative IgG, IgA, and IgM levels. Certain patients have non-secretory myeloma, and they'll just have light chains. Okay, you're gonna look for CRAB, and this differs it from other diseases along this spectrum, where C is CBC, they have anemia or renal involvement, renal insufficiency, usually, but not always, due to CAS, nephropathy. Oh, I'm sorry, my mistake. This C is calcium. They're hypercalcemic, they have renal involvement, they have anemia, and they have bone involvement. And then you do a bone marrow and greater than 10%. So to diagnose myeloma, you have greater than 10% blasts in your bone marrow, greater than 10% rather, plasma cells, greater than 10% plasma cells in your marrow, and you have abnormal protein studies, and you have evidence of CRAB. It should also be noted if you have greater than 60% plasma cells in your marrow and you don't have CRAB, that's still a diagnosis of multiple myeloma. And with that, let's stop.